Great. Okay, so I hope this is the paper Chrissy was expecting me to talk about, because it's definitely...
Yeah, absolutely. This is the one.
Right. Good. This is well, the first thing I should say, hang on. I'm just gonna exit for a second. Hold on, because I'm just trying to scroll through and it's not letting me. Let me just try and fix that. Oh no, sorry guys. This one before? No, it's fine. What we'll do in that case is I will show it to you in the PowerPoint thing. You guys, can you still see that okay?
Yes.
Let me just bring that up a little bit.
Yep.
Yep, okay. I think that will allow me to then move down manually. So yeah, I want to just acknowledge the people who've helped with this particular project, and the principal thing which will come out again is I did most of this while I was doing a master's at King's College London, and Andy Leather, who many of you will know or know of, did an absolutely fantastic job teaching on the masters which he runs, and also he was very kindly my dissertation supervisor, and that facilitated a lot of this work. I was funded from the Association of Anaesthetists and the Royal College of Anaesthetists, and I don't think I've got any conflicts of interest to declare other than that, and the rest of the investigative team, of course, without whom this work wouldn't have happened. Okay, so context. Forgive me for saying the obvious, but a limited surgical workforce does limit our safe surgical care capacity. And as you may or may not be aware, in most countries in the world, the UK being a bit of an outlier, anaesthesia is predominantly delivered by non-physician providers. There are other countries where it is a physician-only specialty, but in most of the world, and quite definitely in most of the low and middle income world, non-physician providers are the big linchpin of the anaesthetic workforce in most countries. And there's an international drive to try and support expanding the workforce, which has been there for a long time, but has certainly had a great deal of encouragement post-Lancet Commission. It's now much more on people's radar that you need the numbers and what kind of numbers you actually need in order to start delivering safe surgical care reasonably widely. If you look at what's out there, and this work I did in 2017 pretty much, and not a great deal has changed since then. Most published work is quantitatively focused, as medical-oriented work tends to be in this field. Most published work has been oriented towards physician providers, although not all. And there is relatively little work looking at the quality of training programs for any anaesthetic providers. There's quite a lot looking at the number. It's often easier to count things than to make more nuanced judgments about them. And we know that obviously not just within this context, but much more widely. All this is particularly the case in anaesthesia. And that sort of got my interest going. So I got involved with a team from Uganda and the US who were also had a sort of burgeoning interest in how non-physician providers are trained. They were looking at that time at doing some quantitative work, which has since also been published, trying to describe in very, very basic terms the number of training programs that exist for anaesthetists in Africa. It was a multi-strategy survey. It was a huge piece of work which I was also involved with. But off the back of that, I thought, wouldn't it be great if, alongside this quantitative approach, which illustrates lots of the need and capacity existing in very numeric terms, wouldn't it be great to start thinking a little bit more about the quality of the training that's happening in some of these training programs? So I took the opportunity of having some time, which was given me by the masters, to do really what had to be a very, very exploratory piece of work, which is the paper that you've been looking at. So the idea was to get the views of qualified anaesthesia providers and their surgical colleagues on the adequacy of what I've called NPAP training. And for the purposes of this paper, NPAP means non-physician anaesthetic provider. You wouldn't believe the number of arguments it is possible to have about how we name anaesthetists. And everybody's got their favourite, and nobody really wants to play nicely with anyone else. But anyway, for the moment, NPAPs is non-physician anaesthesia providers. And just for a bit of background for you, those can come from nursing backgrounds, pharmacy backgrounds, midwifery backgrounds. If they've been through a formal training programme, they probably have come from a healthcare provider background, although it's worth noting that this, beyond the scope of this study, was the large cohort of anaesthesia providers who've not had any formal training, but are nonetheless out there providing anaesthesia care for safe surgery, or possibly not so safe surgery, depending on their experience. It was quite deliberate to be fairly broad, so I wanted to talk to providers themselves, but I also wanted to talk to people with another perspective on what the quality of NPAP training was, and surgeons and physician colleagues of non-physician anaesthesia providers seemed well placed to give some thoughts on that from their own experience. So that's roughly how it was structured, and I inevitably had to take a qualitative approach. My view was that we didn't know what we didn't know. This is not the kind of study where you can form a theory based on good evidence, because there isn't much good evidence. That you could arguably say there's not a great deal of evidence about quality of learning in some areas in this setting in our country. There certainly isn't within the context of anaesthesia provision in sub-Saharan Africa. And what I really didn't want to end up doing was basing a theory or an investigation on my assumptions about what anaesthesia training was or ought to be in a country that I don't know, and for providers that come from a very different background from myself. So it was a deliberately exploratory study using a qualitative approach, and I'm happy to chat more about the design features that I've highlighted there. If people are interested, for me it was a big jump to doing seriously qualitative work from quantitative training background that I've had, perhaps similarly to many of you. But I found it a remarkably powerful way to gain a lot of knowledge and generate a lot of ideas for further investigation. Because it was a master's and because I had 6 months to do this project, I didn't do the whole of Africa. I thought I would try and select 3 countries that particularly differed in the structure of their anaesthetic workforce and how they were trained. And those countries were Sierra Leone, Uganda and Somaliland, which are highlighted there on the map. In terms of the differences between the 3, you'll see from the table that each country has a different principal cadre. Sierra Leone, non-physician providers come from a nursing background. Somaliland, they can come from a variety of backgrounds. And Uganda, they come from what's called a clinical officer background, which is an alternate sort of mid-level provider training system. Uganda's been running its non-physician training the longest, and Somaliland is the most recent. And the people who deliver training also vary. So in Sierra Leone, the training programme for non-physicians is nonetheless delivered by physicians. In Uganda, it's held onto by anaesthetic officers who teach their own, as it were. And in Somaliland, interestingly, their training since 2011 has been delivered from Kenya by Kenyan nurse anaesthetists, albeit with the input and help of physician anaesthetists from time to time, who are also from Kenya. Like I've mentioned, there are other non-physician providers in the country, and those were beyond my scope to even track down often, but also beyond the scope of this investigation, which was really focused on the formal training programs that people have been through. And then just that final row gives you a sense of context. In Somaliland, there are no physician providers of anaesthesia. In Uganda, there are now more than 40, which is quite a rapid growth in recent years. And in Sierra Leone, I've put fewer than 5 because it changed during the duration of the study. I think it's currently 3. And actually that dynamic really shifts how people perceive non-physician anaesthetists and how they perceive themselves. And again, that's slightly out with my primary interest, but it did come up during the interviewing. So data collection was based on an interview guide, but really I was keen to be directed by the subject. As I've said, this isn't somewhere I felt I was ready to generate theory and therefore just test it with some directed closed questions. I was much keener to ask the basic question, you know, what did you think of your training? Did it suit you? Did it prepare you for what you now do? And see where we went. The aim was to get what the qualitative researchers call rich, thick data from a small number of subjects. So again, that's a bit different from a lot of quantitative work that we do. I recorded and transcribed it, and I would recommend that, by the way, if you ever do qualitative work. Transcription is absolutely painful process, but there is no better way to get familiar with the data that you're collecting than by doing that. My top tip is play it at 1.5 times normal speed, personally, but you will have you find your own solutions if you end up doing it. And then analysis was based on something called a thematic framework approach, which is essentially a process of looking through the ways that people talk about training, different backgrounds from different interviews at different times, and trying to find themes. Characteristically, those often start off as very descriptive. You know, you say, well, everybody talked about their first day at work after they finished training, and that's a sort of a low-level theme. And then you, as you read through again and again, you sort the data, you start to see more kind of abstracted and conceptual and arguably more useful themes coming through. My interest was to explore the common themes between the 3 countries, rather than to explore a lot of differences, because I felt that having chosen 3 countries which were relatively different training-wise, the value was probably in identifying things that seemed to be common across those different contexts. But you could take a different approach, that's just the one I took. All the data was then second coded, so I coded initially, developed some themes, developed some ideas, and then got the data reviewed by at least 2 other researchers independently to see whether I was really reflecting it fairly. And we met a couple of occasions to go through and fine-tune and agree our conclusions from the data. So the things that were in common were not what I was expecting, really. I think if you'd asked me before I started, I would have said everyone will talk about resource scarcity, everyone will talk about conflict between different cadres, everyone will talk about not being able to learn things they needed to know. And in fact, the 3 emerging themes which seemed to be most important in people's views when they looked back on their training were the 3 that I've put there, of which the first one is probably the only one I would have really predicted, the urban-rural disparity. This is shifting a little bit, but it is still the case that most non-physician training is delivered in the capital or a large city in the 3 countries I looked at. But characteristically, lots of non-physician anaesthetists are deployed to rural settings. We know that physicians tend to congregate in cities for a whole variety of completely understandable reasons. And because urban and rural practice in anaesthesia it can be extremely disparate, they find sometimes that their training just wasn't sufficient for the rural setting. And the classic there is the use of ether, which people in this country don't believe is still used, but is still used worldwide. In Uganda, particularly upcountry, ether is used in the district hospitals, and it's never seen in Kampala, where the majority of clinical officer training has been done to date. Now that's being corrected as we speak with an increased focus on some rural deployments during training, which is helping a great deal. But nonetheless, we saw that that was the sort of key thing that really came across in all settings, was that the urban to rural difference wasn't adequately prepared for in training. The second 2 were a little bit more of a surprise to me, in that they reflected what people valued about their training, and it wasn't what I expected. the non-curricular learning often came up. People wanted to talk about the things they learned around the edges, the ways they grew as a clinician and as an individual during their training. And it just, I felt it was worth highlighting, well, partly because I really think it emerged quite strongly from the data. But I think the secondary value of discovering that is that we realise the importance that trainees and those who train subsequently put on the things that aren't really given a lot of explicit attention in curricula. And the two that I particularly noticed were the learning to learn paradigm. So people coming in and trying to access knowledge and learning and how they grappled with that. So I think I've put a quotation in the paper somewhere of one anaesthetist who used to come in at night because that's when she could get her hands on. She was desperate to learn. She was there was too many people there during the day, so that's what she did. People go to the internet. People worked hard over and above, and they were relatively conscious looking back on that process of learning to learn, although they never said that they'd had any formal instruction in that. And then the second thing, which I've not seen a great deal written about anywhere, high income or lower middle income world, was this perception of the development of clinical responsibility, the steps from I don't have control, I can't do anything, to I have some knowledge, I have some skills, and I have some responsibility therefore for my patients. And again, that came over very consistently from people in all three countries, that shift. And it would be interesting to know how different or not that is for physicians, but certainly for the non-physician providers, the shift to the responsibility of giving a safe anaesthetic during their training, again, not formally taught, but something that they really valued. And then the third point is the relevance of training relationships for later practice. And this was huge. So one of the topic guide questions I had in mind, if conversation ran dry during the interview, was to ask about difficult cases in their practice and how well they've been prepared to handle them. And what came up through that was much less about techniques, skills, and adequate training, and much more about the dependence on relationships formed during training for helping them out during difficult cases. So they call their teacher, they call someone they met, they call someone who was friendly. And in Uganda, where there is, not in all cases, but there is certainly a bit of an issue in some areas with conflict between the non-physician and the physician cadres, actually those who had trained together in the same hospital and were sort of familiar and had built bridges, as it were, across that cadre gap, had lent on that quite heavily in later practice. And interestingly, not only was that the case for non-physicians, but it also, although it was beyond the scope of the question, physicians said the same thing, that developed relationships they've developed with non-physician anaesthetists also got them out of trouble in later practice, which was kind of an interesting sidelight. So in terms of kind of limitations, it's again, this is a difficult one to answer when you are like me and you come from a strongly quantitative biased research background. I had to sit down and think about what the transferability, generalizability issues are in this kind of qualitative project. And I think the answer is you don't assume you can generalize any of this. This is an exploratory study which is aimed at generating ideas of development and investigation rather than a theory which is going to be applicable across. It's absolutely true that there's a biased, completely pragmatic issue because it's much harder to find others, but the result is you're learning a living as an anaesthetist as opposed to having dropped out, failed, or otherwise been dismissed. There's an English language bias. I interviewed in English, and all participants were comfortable to speak in English, but for some of them it was their second or third language, so undoubtedly nuance was lost there. And it meant that I wasn't ever going to interview people from non-Anglophone countries. And important, I knew one or two of the people I was interviewing prior to the study, and they all knew that I was a physician, that I was female, that I was white. Well, in fact, I don't know if they all knew I was white because we didn't manage video link on all the interviews, but anyway, they probably guessed. And so how they phrase things and what they say might be affected by that. And certainly how I analyse data is probably also affected by who I am as a clinician. I think that is something that you don't ever get rid of completely, but it obviously has to be borne in mind in interpreting results. So in terms of the reflections I have on this particular piece of work, for me, it was the first really serious attempt I'd made at doing some qualitative research in what I regarded as a fairly safe space with the master's team all around and able to advise me. It's certainly informed further interest. I'm particularly interested in the clinical responsibility paradigm. I'm particularly interested in the way that networks operate between providers in all countries, but particularly in the low and middle income setting where they're often geographically remote. And those are the areas that I'm sort of moving on to look at now. It also became quite obvious to me that there was a need to develop research capacity within the non-physician provider community. I was very keen to do this project with a non-physician provider, but I was unable to find one who had the time, even were I able to find them the funding. Equally, I recognised that many of them didn't have training in research, and therefore that would be something that we would need to work on. As I say, yeah, I couldn't find a collaborator within that community at this time. So the last slide I have is actually just off the back of that, and it has nothing to do with this paper, but it is just to mention to you that with a few spare dollars, or any non-physician anaesthetists in Africa, you might want to point them at this, which is happening in June. This is I think it's potentially a game changer. This is the first Pan-African nurse anaesthetist conference. It's actually open to any anaesthetic providers, but it's aimed at non-physician anaesthetic providers. It's bringing up research focus. It's starting to get people networking and talking to each other. This is often a very isolated group of providers. They are looking for funding to support people to come. And also just for the word to be out and relevant communities so that people know it's there and they can support it. I think that's everything I wanted to say. Bit of a race through, sorry. Over to you, Kriti.
Thanks very much, Dr. Edgar. That was really valuable. I think I personally very much appreciated your reflections on the difficulties in transitioning from a quantitative to a qualitative researcher, because I don't know about other people who are also present, but I have absolutely no qualitative training at all, and I think it's a burgeoning field, especially in global surgery, where, like you said, we're trying to figure out what we don't know. I suppose we can open up to the floor if anyone has any pressing questions to start off with, and then we can move through from venue to venue to make sure everyone has some time to let us know their thoughts.
We have a question from London. Just introduce yourself to one.
Sorry, my name is Nalaga. I'm a higher surgical trainee. I actually spent 2 years working in Uganda, so I'm pretty familiar with in some of the hospitals, non-physician anaesthetic provider setup there.
Yeah.
Sorry, I may have missed. How did you interview these people? Was it?
Oh, thanks. You didn't miss it. I forgot to say anything about that. Yeah, so it was all remote.
Yeah. Okay.
That was, it was driven by a pragmatic consideration, which is that I was also holding down at 80% part-time job in the NHS, so I didn't have the time to go to the places. Interestingly, when I looked for sort of the pros and cons, when I was thinking about whether it was a reasonable approach to interview remotely, I found quite a relatively high amount of support for remote interviewing. You lose a certain amount in body language, and as we all know, there are barriers in the online communication and dodgy connections and so forth that can affect the fluency of an interview, for sure. There is a thought, I wouldn't say it's really data yet, there is a thought that online interviewing may make some interviewees feel more comfortable because they feel they have more control of their situation because they're not right there in the face of the interviewer. Anyway, but I had to do it anyway. So the plan A was to do it over Skype. Some places had pretty good connections. Somaliland had great Wi-Fi in all the places I was talking to people. And some didn't, and we ended up on WhatsApp. And in terms of, that was pre-Facebook ownership of WhatsApp, which made the data management side slightly more straightforward. I would have to look into it again if I was thinking about doing it at this stage. Just bearing in mind that every online provider you go through, in theory, has access to your data as it goes by. So yeah, so it was Skype and WhatsApp.
Another question?
Hello, my name is Katie Hughes. I'm a surgical trainee and I'm a member of the Association of Surgeons in Training. Did you look at attrition much of these trainees? Because it's easy to perceive it as a very kind of challenging environment to work in, be that out of possibly my own ignorance. But is that something you explored with the interviewees at all?
Yeah, so not in enough depth to feel I'd got a grip on it. I guess I got some hints around it from some areas. So there were places where people would talk about attrition of providers post-qualification related to inadequacy of pay or career progression. And it came up a little bit in the urban-rural disparity theme, that somebody would say, you know, if you teach people to use all the fancy stuff in the city and then they move somewhere where they've only got ketamine and they give ketamine anesthesia for 10 years, it's not surprising if they get a bit discouraged and a bit worn down and, you know, they don't feel they're doing the best for their patients, and then you lose them. So that, it came up. I didn't make any kind of estimate of numbers. I think the other point on attrition is what we did talk about with most providers, although it wasn't sort of one of the strongest themes that came through, was whether it was easy to pass the end exam or whatever assessment they had to do to finish their training. And interestingly, in Uganda and Sierra Leone, the views of the people I spoke to, though again I don't have the numbers from the training institutions, was that for sure some people didn't pass, but then they would expect to repeat a period of time up to a year, and they would probably pass the next time round. Whereas in Somaliland, the pass rate was under 50%, which I thought was interesting. I tried not to overread it because I know the Kenyan training system quite well and the people who were delivering the training in Somaliland, and I know that they operate to a very, very high standard and they are not interested in passing people who don't meet it, and that was very important to them, but that wasn't really the data that I got from this study, so I didn't feel I could present that in a lot of detail. And then the other attrition rate, which was a little bit new to me, and again was more of a minor theme, and therefore not presented in the paper, was the attrition that happens before people start training. So in most places, quite a lot of people apply and are accepted and then can't come because they haven't actually got the funds, or in most cases, I think it's because their hospitals find that they cannot release them for training. And that, you know, that's new, as in to me from a UK background, although I was not totally surprised by it, and that was something certainly that came up. So it's kind of a three points of attrition really. There's pre-entry to training, there's during or at the end of training, and then there's in working life afterwards. But yeah, it'd be good to have the numbers. Quite hard, I think.
We've got a question from Lisa.
I'm one of the FU's leads wanting to do anaesthetics.
Great, good choice.
Am I right in thinking that you interviewed the non-physicians, physicians and surgeons?
Yeah.
And were there differences in opinions, or could you really notice differences between the groups?
Yeah, that's interesting. So I did look at group differences fairly early on in my analysis, and it didn't really take me anywhere. Just reflecting back, although I haven't looked at the raw data for a little while, I think, not at all surprisingly, and this was part of the study design really, the non-physician providers were often, they would often speak with much more confidence about the experience of training, obviously, because that was the subject. Whereas the surgeons in particular were much more focused on, well, when I come in, you know, and I have X anesthesia provider, then I know it's going to be fine, or it's not going to be fine, or, you know, they're sort of their experience as surgeons of the providers working now. And I found that I didn't get much that was super helpful in terms of their reflection on non-physician providers training, other than as a sort of gaggle of people at the head end when they were trying to get on with an operation. So I guess it was an interesting perspective, but it didn't take me, I'm glad I did it, but I think if I were following on, I would probably focus on the providers group themselves going through training, and then I would probably be more focused in talking to other people who were involved in training. I think my thought initially was perhaps I would find that the surgeons would say, oh, I wish they could all do spinals, but they can't, or, you know, that kind of information, but that didn't really come across. I think one thing that perhaps they hinted at, but it was a pretty small group of, I mean, it was a really small group of surgeons, but I think a couple of them said, we like how the physicians talk back to us, essentially. I mean, they didn't put it quite like that, but they basically said, you know, we value the fact that we're not looking over our shoulders at what's going on with the anaesthetic when we have a physician, and that's a fairly consistent finding with physicians, whereas when we work with the non-physicians, some of them are like that. They're very experienced, and we know that they are a good safe pair of hands, but others of them we feel like we need to keep an eye on the fluids and the drugs, and that's hard to do while you're also doing the cesarean or whatever it is you're doing. So, so there were hints of it, but it wasn't a huge mine of data.
A question. So thank you for sharing that. In terms of, so you spoke about how sort of developing relationships in a professional setting, that being useful for seeking help in clinical practice later on. Did you find there were any frameworks in place anywhere a bit more formally to sort of cater for that, or was it quite?
What a fantastic question. I mean, basically that needs to be the next study, and it only requires me to have the time to sit down and do it. Yeah, so that is exactly the next study. So basically some places, some hospitals have protocols. You know, this kind of case is done by this kind of person. So that kind of task allocation, as it were, in some places is written down as policy. In other places, they had, I think one participant said, oh yes, we have a silent system. Just everybody knows that this is okay for a non-physician to do and this is not. So task allocation is one thing. What I have not really got to the bottom of is whether many or any institutions in these contexts have guidance on the wider issues in task sharing. So referral, advice, supervision, mentoring, support. I think that's completely fascinating. And essentially what I'd love to see, you know, and if anyone wants to kind of get involved with this, I'm kind of looking for people who've got time to help, is work, first of all, a decent literature review. And second of all, probably then a survey initially approaching institutions in as wide a geographical area as we can manage to say, do you have any policy? What I think is then going to be the interesting bit is then to say, okay, how does what they call declarative work, what should be happening, actually match up to performative work, what's happening on the ground, and why or why not? Because there's a lot of talk about task sharing being a great model, and it's defined in some countries in the West, which again would be interesting to look at, although it's not called task sharing much in the West. But it seems to me something that everybody is saying we should be doing, and nobody is really talking about how or what it looks like, or indeed what already happens. So I forget whether I put it in the paper or not, but there's Somaliland guys who were all recently trained. All the people I spoke to there were trained within the last 3 years of me speaking to them. Well, one of them, regularly takes calls from people who are in remote areas, anaesthetists who are in need of support and guidance, and they're doing an emergency and it's not going to get referred or transferred, they're going to do it, and he'll do it with them by phone. So they'll stick the microphone and the camera on WhatsApp and listen to the beeps and look at what's happening, and they will do it together, which is just not something I've ever seen outside that context. Quite interesting.
Thank you.
Excellent. I think we'll move on from the Leeds venue and see if anybody else has any questions on the other sectors.
Right, just to introduce a couple of groups who are with us right at the start. We have Dr. Mohan from Cork joining us all the way from across the sea. We have student groups from Edinburgh. So we have Violet from Edinburgh and Vigneshwar from York also. Right. Anybody else with any questions for Dr. Aitken? I can't see if anyone else is raising their hands. No, they're not. Okay, do interrupt me if you have something to say. I just found it really interesting because as a very new junior doctor, a lot of what I related so much to a lot of what the NPAPs were saying about taking responsibility for learning, self-directed learning. So a lot of your points 2 and 3, I found were, I could relate quite a lot to them. And I just wonder, obviously there is this mentorship, which is technical mentorship in terms of physician anaesthetists to NPAPs. There also seems to be, perhaps this is way beyond the scope, but there also seems to be some potential for not mentorship, but just sharing of experiences and grievances just commonly across people, across cadres, across new doctors and NPAPs, not just in low resource settings, because these all seem to be common experiences that people across the world are feeling, and it can be really helpful to mitigate that sense of loneliness where you feel like you're the only person that doesn't know something. I don't know whether you feel like that might be helpful for the NPAP cadre, whether that was any.
Of course, they're doing it actually. So I mean, again, it wasn't the direction of this particular study, but they would talk about, they have WhatsApp groups where they talk to each other that were formed. Again, this is relationships they made during training. When they go out and they're the only person in their hospital, and they just do a one-on-one on call. Actually, they do kind of contact their buddies and have a moan or whatever. I think what is very difficult for lots of people in the most remote areas to do is to leave their hospitals. So, the coming of internet access is a great help from that point of view, but I think it doesn't necessarily mean that we shouldn't be encouraging and supporting face-to-face meeting, because there is something, I would say, I think different and useful about that. And I was very struck too, when I was sort of pulling this out, and I was like, well, hang on, I see this in my registrars, I see that shift from, I don't quite know what to do and I'm a bit worried that I might make a mistake, to I think I know, but let me just call and make sure. Through to that, actually, I'm going to take hold of this. This is my patient. Even if the consultant tells me something different, I'm confident that I know what needs to be done and I'm responsible for them, and they're mine, not Dr. Edgecombe's or whoever. And I think that's a really interesting transition that we don't mark. I may have just not looked in the right places yet, but I haven't really found anything written about how that develops, particularly.
Thank you very much, Hilary, for your presentation, which was very clear, and I thought your paper was really nicely written and easy to read, and you describe your methodology very, very clearly. It's easy to follow. What do you hope to be the outcome from the work that you've done? In your introduction, you state that your intention was to try and use a qualitative approach to essentially ultimately improve quality of training by exploring provider and, in the case of surgeons, I suppose, recipient views of that training experience. What do you think the outcome of these findings would be?
Yeah, I guess it depends how many steps forward you're prepared to take from this paper. So my expectation from this particular piece of work is my optimistic expectation is this is a little bit of work acknowledging this group of providers who are almost invisible despite being an enormous group. So I think at the lowest level, I wanted there to be something in the academic literature saying these providers exist and they have views and they are experts in their own training experience. And so it is a bit crazy if we're going to talk about how we train non-physician providers, and that is where the sort of discourse is going with the World Federation of Societies of Anesthesiologists and so on. If there aren't people talking to this group of providers, well, there's a bit of a tendency for physicians to decide that they know what's needed. There are kernels of truth in that, but it's not. I don't think it's the whole story. So I guess that's a sort of a contributing to the literature kind of expectation. I think in the longer run, when I started the study, my hope was that I would generate some ideas for further study and for guidance as to where we should be looking when we are thinking about quality. I'm not sure I feel we've completely got to the bottom of that. This was a very small study. It has given me ideas of where I want to look next, which are based on my interest. I think, I think the non-curricular stuff warrants a little bit further look, but the problem with that is it's pretty difficult. It's much harder to count cases and do logbooks and look at outcomes. And of course, until we look at patient outcomes, we can talk about quality all we like, but we don't really know which are the low-hanging fruit to go for, first of all, with non-physician training. Sorry, I'm not completely sure I've answered your question there.
Well, it's interesting to hear. It was just a question I was asking myself was, I suppose it's a challenge because, as you say, you're investigating a field in which there's very little written, and you just don't know what it's going to bring up. I would have been interested to know what their perceptions were on levels of resource available to them when they were training, for example, and as you say, it's interesting that they didn't focus on that, and people have more talked about how in their motivation they found ways around crowded training environments rather than
I think it's interesting too, and it certainly isn't the case that they're not talking about it because it doesn't exist. We absolutely know that it does, and that's increasingly well documented now. I guess there are a few potential explanations. It's interesting that also one of the reviewers of the paper said, why have you not focused on resource limitation? You know, we all know that's important. And I thought, yeah, that's interesting. That's why I've written this paper, because we all think that's important. Possibly one of the reasons for that is it was so completely the air that they breathe that they didn't think it was notable. So rather than focus on resource limitation, they talked about difference between environments that they'd encountered, rural thing. So that may be it, yeah.
It's been taken, do you think, to try and improve the applicability of training to rural practice, which I presume would be more likely to be where non-physician anaesthetists practice in some settings?
Yeah, nothing really came out of that from the Somaliland group. In Sierra Leone, they have a sort of rule there. So one is that during training, they are asked about hypotheticals. Supposing you don't have this, what will you do? You know, although they don't experience it, they are asked to imagine and plan for that. And then also in Sierra Leone, their trainers do basically a tour of the hospitals to which they've been deployed, which is, I think it's probably a slightly mixed purpose visit. You know, they go in and they have a look at logbooks and what have they been doing and are they all right? And so there's a little bit of support offered there in the rural context from the urban. Then in Uganda, increasingly people are starting to get deployments from their urban training centre out to district setting. Very involved with setting up a new non-physician provider training programme, which is one of the reasons he's interested in this. And because there are now so many training people coming through training as non-physician providers, they can't train them all in Kampala. So they are all, you know, there are several centres which are not rural, but are more rural. And then from those, people are getting a little bit more exposure to some of the techniques that they'll need. Obviously, the long-term game plan is that there shouldn't be a difference. So the question is, how far do you push resources into preparing people for difficulty versus trying to get rid of the difficulty? But that's the big question in global health.
Thank you.
Any further questions from the floor? Sorry, I know that. Yeah. Sarah.
Hi, sorry, I have just maybe it's a silly question, but just I was wondering, did they provide any feedback on training after they had left their training, like as in like continued training, and if they would, because I know a lot of our training here, I'm an obstetric trainee, and like I feel like I just scratched the surface in medical school, and now I've like logbooks and many courses. So like, had they provided much feedback as to whether they thought that was a huge gap in their thing, being able to access further training, or?
Yes. Yeah, absolutely. I mean, again, it wasn't, I limited my kind of field of focus when I was looking at data to the original training program that they'd been through. So if you just come through that training program and you didn't do anything else, were you adequately prepared for the job? However, it absolutely came up with all of the need for ongoing education and the limitations or the difficulties that they faced in getting it. That was universal for sure. And again, I think it's part of arguably it could be part of a bigger look at how task sharing operates and how networking operates between providers in these settings, whereas it's harder to get leave and so on. Yeah, a lot of them are using, I mean, again, the internet's amazing. A lot of them are using YouTube to teach themselves things. And some of them have conferences, then some of them can get to them, but it's much less of a thing than it is here.
Time for, I just had a quick question actually.
time for one more question?
Yeah.
I was just quite curious if there was any, if on speaking to the physician anaesthetist and the non-physician anesthetic providers, the ones that had finished their training, if there was any sort of mention of what are the main kind of differences in their training between the non-physician anesthetic providers and the anesthetic trainees? Like, were there any kind of, what were the main differences between?
Yeah, so I guess I didn't, when I was talking to physicians, I was really talking to them about the non-physicians that we're working with. So I didn't spend a lot of time talking about the structure of physician anesthetic training. It doesn't exist in Uganda, in Somaliland at all. B, it didn't exist in Sierra Leone until very recently. So Uganda is actually the only place that's training a significant number of physicians at present. So I didn't go into a lot of depth with that as my primary focus. It came up. So some of them said, we want to learn some things that we know on the physician curriculum. Nerve blocks was quite a common thing that doesn't seem to make it into non-physician training curricula. I guess I didn't go down that route, or it didn't come up, and I didn't push down that route much, partly because I knew that the survey that we were doing simultaneously, which I can send through the link to if people are interested, to the paper, was going to explore that. Do you teach X in your training program type stuff? I think the thing that did come up very consistently in Uganda was the competition between non-physician and physician anaesthesia trainees for exposure and experience. But that was, as I said, that was just that one setting.
Thank you.
Excellent. Thank you very much. Thank you very much, Dr. Edgecombe, for
Thanks for having me.
Giving your expertise on this topic, and hopefully we can have you back again on the Journal Club.
Yeah, they'll write something else. Okay.
Over to you, Kriti.
Thank you. Thank you very much.
Thanks very much. I'm gonna attempt to leave the meeting. I'm sorry not to be able to hang on till the second part, but I think it's really interesting.
Thank you.
Thanks.
Thank you very much.
Right, so the next part, I don't know, I think I'll leave it a little bit up to the floor actually. Would it be useful if I did the summary, or would you all just like to launch straight into the discussion part? Just a show of hands quickly who'd like me to do a quick summary of the next article we're talking about with task sharing for cesarean sections.
Yeah, I think you should do a short.
I think it'd be worth summarising it quickly.
Okay, all right. Let me, I'm going to try and share my screen again. This one. Right, do you see a PowerPoint presentation?
No, hold on.
Oh, fantastic, okay.
Yes,
we do now.
Yes, okay, perfect. So, very quick fire tour of this, I'm afraid, because I just want to maximise the amount of time we have for discussion. And I think I will also, let me see if it will let me scroll, it may not do. So this is a study by Van Duinen et al., which was published very recently in the British Journal of Surgery. And I thought it would be nice to discuss it because it very much relates to what we've been talking about with regards to task sharing, but this is a quantitative study, a little bit different. Okay, it won't let me scroll, so... Oh, yes, it does. Ye of little faith. Okay, so the study question over here was in over 9 hospitals in Sierra Leone where both associate clinicians and doctors performed cesarean sections. Did cesarean sections, and these include laparotomies for uterine rupture, performed by associate clinicians, compared to cesarean sections performed by medical doctors, result in a non-inferior 30-day maternal mortality. So that was their primary outcome between October 2016 and May 2017. And the primary outcome, they looked, subdivided it out into intraoperative death, in-hospital death, and death after discharge. Secondary outcomes-wise, they looked at perinatal events, so that included stillbirths and neonatal deaths, and a sort of third category, perinatal deaths, which included fresh stillbirths and early neonatal deaths. The stillbirths are categorised as fresh or macerated, depending on at the time of birth, did the infant have skin changes associated with death before the onset of labour. The secondary outcome they looked at was maternal morbidity, so that included blood loss greater than 600 mils, reoperation, readmission, wound infection, post-operative pain. To set this in just a tiny bit of context, essentially because of the lack of medical doctors able to perform caesarean sections, the Sierra Leonean government has invested in a cadre of associate clinicians. So these are non-specialist doctors and other healthcare professionals who do a 2-year training scheme to be able to perform emergency surgical and obstetric surgery. So let's move on. This study was interesting because it is, move on. One second. Let me just stop sharing and show you from here. It's not letting me.
I think there may be a little bit of a problem when you go into full presenter mode.
Yeah, I think so. Let's stick to this one. So it's a prospective observational multi-center study, and the important exclusion criteria I thought I'd mention is they excluded births where the fetus weighed less than 500 grams, and where the essential data was missing, and they classified essential data as data missing, which made it difficult to follow up to 30-day mortality. And I just thought I'd go into a little bit of detail on what a non-inferiority study actually was, because I thought that was quite important in interpreting the outcomes. So essentially, a non-inferiority study is looking at whether something is unacceptably worse or not than what it's being compared to. So it's not looking to demonstrate a difference in terms of superiority. So we're not trying to say this is better, or we're not trying to say it's equivalent. That might seem obvious, but as I've put in italics below, the purpose of the study is not to establish a point estimate of the treatment effect. And I think that's quite important when we try and interpret what they're showing to us. A lot of my understanding of non-inferiority studies, because I had absolutely no understanding before I started reading this paper, comes from the reference I've put in below. And if anyone's interested in this methodology, would highly recommend that reference, Through the Looking Glass, Understanding Non-Inferiority. The graph at the bottom sort of shows what we're trying to do. We're trying to establish what is unacceptably worse using a non-inferiority margin. So that's the dotted line here. And there are a number of possible outcomes of a non-inferiority study. If you're here, if the upper limit of the confidence interval falls below the non-inferiority margin, what it essentially shows is that the new treatment or intervention that you're comparing to the old treatment or intervention is inferior. I'll move on a little bit. I've got here some details of how the numbers were calculated. I think what's important to emphasize is that in order to calculate the non-inferiority margin, that sort of dotted line we looked at there, they needed some data from previous studies. So they assume an average maternal mortality rate after C-section of 2% from previous studies in comparable settings. And they assume an odds ratio for maternal death after associate clinician C-section of 2.75. And they say, actually, this is a suggested non-inferiority margin of 5.5%, but we don't think that's acceptable. That's not acceptably worse, so we're going to reduce it to this non-inferiority margin. And yes, as I said before, I think it's worth looking into the other reference if you want to look into the details of how those numbers came about. They did a sample size calculation using these numbers, and essentially their null hypothesis was these sections performed by associate clinicians have a 30-day maternal mortality 2.5 times higher than those performed by medical doctors in Sierra Leone. So that 2.5% is their non-inferiority margin. So just a little bit of preliminary data. I think these were all of the hospitals they looked at. So there were 9 different hospitals they looked at. PNP means private non-profit. So there are 4 district hospitals, 1 regional, 1 tertiary, and 3 private non-profit hospitals. I've just highlighted in here a few interesting numbers. I think overall, so we have 12 associate clinicians and 50 doctors across all of the hospitals in the study. And the number of procedures performed by associate clinicians were 443 compared to 831, which doesn't quite fit with the ratio of AC versus doctor. So I guess we can talk a little bit about that, but I just thought that difference in ratios was interesting. There was only 1 hospital in which the number of associate clinicians was greater than the number of doctors. So that's the private non-profit Magbenta Community Hospital. So the total number of cesarean sections they looked at the beginning was 2,303, and the total number they include at the end was 1,282 because of different things being excluded. Overall, their attrition rate was actually not bad at all. So they had less than 10% attrition rate for both arms. And they ended up analysing actually not only those that they were able to do a follow-up home visit to 30 days later to assess the 30-day mortality, but they actually analysed everyone they had in-hospital data for. Hope that's, sorry, I know I'm rushing a little bit, but they essentially analysed everyone from before the loss to follow-up, if that makes sense. Okay, so significant differences between the 2 groups. Associate clinicians performed more surgical procedures on women with twin pregnancies than, oh no, that should say that. Associate clinicians performed more surgical procedures on multiparous women than doctors. The doctors performed more out-of-hours and emergency procedures than associate clinicians did. And doctors also performed more emergency procedures such as caesarean hysterectomy, caesarean with B-Lynch sutures than associate clinicians. Doctors as a whole were more experienced when it came to the number of years of experience they had after graduation than associate clinicians. Primary outcome, so they had a total of 16 post-op maternal deaths, so 2 intraoperatively, 11 in hospital, and 3 at home within 30 days of birth. One of these deaths was due to after a surgical procedure, not due to, done by an associate clinician, and 15 of these were treated by a doctor. The odds ratio, so they had a crude one and they adjusted one for clusters, so the 9 different hospitals, was 0.12, which fell in their interpretation well within their established non-inferiority margin. So you can see the confidence intervals below. And there were no significant differences with regards to their secondary outcomes, either with regards to maternal morbidity or perinatal outcomes as a whole, and within the subcategories of stillbirths, perinatal deaths, and neonatal deaths. So the conclusions they draw from this study are that surgical procedures performed by associate clinicians are non-inferior to those performed by medical doctors in this study, and that task sharing for caesarean sections is a safe way, is safe in Sierra Leone. So that's the way that they've interpreted their data. And now I'll put up here just some points for discussion, just some food for thought, and we'll open it up to the floor. Sorry, I feel like I've stunned you all with my speed of talking a little bit. I suppose maybe I should expand a little bit on the points for discussion that I've put up there. I thought what we could maybe think about was a lot of the calculations of the non-inferiority margin, a lot of the answering of the question, what is unacceptably worse, was based on data they had before for the maternal mortality rate for comparable situations. So they looked at meta-analyses from sub-Saharan Africa, looking at the maternal mortality rate, and they picked the highest sort of maternal mortality they could find, which is 2%, because Sierra Leone is known to have one of the world's highest maternal mortality rates. But the maternal mortality rate from this study was actually 1.2%. So that sort of brings into question a little bit their numbers, but I'll leave it up to you to sort of discuss whether we think the study was adequately powered and whether they picked an appropriate number for the non-inferiority margin. A second thing I thought we could think about was these two groups have some important differences, specifically the emergency surgeries and the types of surgeries performed and the experience. So the non-inferiority, I guess, has been demonstrated here for these specific conditions. So I don't know whether we think there's, I'm being very leading here, I'm trying not to be, but maybe there's a question of conditional non-inferiority and what happens if we interpret these results as being non-conditional, just saying, you know, associate clinicians can perform the same sort of procedures as medical doctors and their cesarean sections are just non-inferior. Yes, I will definitely stop talking now. Let me stop sharing. I can bring up the figures if you need to at any point.
I apologise first, I haven't read the paper, I actually didn't realise it was up for discussion. Did they clarify what a medical doctor was? Was this a generic doctor without obstetric training?
Yes, so they included within the associate clinicians non-specialty doctors. So medical doctors, I think, are doctors with postgraduate training in doing obstetric procedures, including cesarean sections.
I think I'd be taking my chances with clinical officers. They're doing it all the time, anyway.
Just in
Yes,
terms
that's
of,
an important point. It's quite a heterogeneous group, isn't it? Associate clinicians. It would be hard to have a clear grasp on their level of training and experience. I don't think they state that in their paper, do they? The sort of baseline experience that these particular individuals had. I don't think we have a sense of that, do we, Krithi?
Sorry, could you repeat the question? You just went a bit crackly at that point.
Well, what I was saying was there might be a slightly greater uniformity to what they describe as medical doctors versus associate clinicians, because the associate clinicians could well have a very considerable volume of experience.
Mm-hmm. Definitely,
It's
and it looks like, sorry, yeah. I think if we look at the spread of the years of experience that they have, it definitely looks like the associate clinicians are a more heterogeneous group in terms of how much experience that they've got. Maybe I will share my screen again. There we go, here are the numbers. Oh dear. It definitely looks like the associate clinicians are doing more than their share of obstetric procedures compared to general surgical procedures. I think that's why I was interested in these numbers at the bottom here. So your ratio of ACs to doctors is 12 to 50. The number of surgical procedures included in the study performed by ACs is more than half of those performed by doctors altogether. So the volume, in terms of your comments, Stuart, in terms of the volume of experience, it certainly seems like ACs have a lot of experience in performing these procedures in the study, but it's not possible to say, like you said, to rule out heterogeneity in their level of experience.
But could that be a confounder as well? Are they more prone to doing the procedure in someone in whom that might not be indicated? I mean, are the initial indications taken into account? Is that why the outcomes could be different as well?
They are not taken into account, but there is actually a study in the references which looks specifically at this question, actually. What are the indications for surgical procedures in obstetric situations performed by associate clinicians versus medical doctors? And they have found no differences in that study. Admittedly, I haven't looked into the details, so there might be biases within that study that I haven't taken into consideration, but there is literature on that. And of course, we don't know the indications for this particular study, so it's very difficult to extrapolate.
Quickly, just one thing when you said the numbers may be brought up into question because Sierra Leone has a high maternal mortality rate, but the mortality rate in this paper is only 1.2%. So that was mortality rate specific to cesarean section, not overall mortality rate, right? So in a setting like Sierra Leone...
So yes, sorry, yeah.
Yeah, in a setting like Sierra Leone, I would imagine a fair few of them probably have lack of access and so die prior to even having a cesarean section or from other causes as opposed to secondary to the procedure. One quick question as well, was there a difference in the type of hospital and where the different types of clinicians worked?
Yes, let's have a look at the...
it's quite interesting because they do break it down. There's one tertiary centre they talk about in Freetown where the proportion of doctors is massively greater than the ACs is 19 doctors versus 2 ACs.
Because again, like your higher risk patients will be referred to your tertiary hospital,
Exactly.
which is mainly operated on by doctors. So there are a few kind of biases that are gonna confound.
Because it's the feeling kind of that if you look at the primary outcome alone, that postoperative maternal mortality was so much higher in the doctor group. Are we assuming that's just because these are higher risk pregnancies and also because there was a much greater proportion of emergency cesarean sections done by doctors? I think
I think by the time they kind of transfer to however long it takes and they get to Freetown, they're significantly sicker.
Also, I had a bit of a question about the breakdown of patients in their kind of groups. It's kind of, you know, null-ups, multips, grand multips, but like they didn't seem to have commented on how many sections somebody has had before.
Yeah, exactly.
So they do put that in the paper.
Okay, right.
Yeah. But there's no significance between the two groups. I can read out the numbers if Chrissy hasn't got them in front of her.
Sorry, yes, do go ahead. Sorry, I didn't include that because there wasn't a significant difference, but yes,
so,
that would be helpful.
Basically, in both groups, about 80% had never had a cesarean section. Around, being very averagely, about 12% had had one previous, and around 5% had had 2 or more previous cesarean sections. And that's pretty comparable between those performed by ACs and doctors.
That seems like then they'd have a reasonably high rate of multiple sections and people who had not had a section before. Right. Anyway.
Sorry, can you see the entire table now? I've tried to bring it up. Or...
Oh yeah, thanks.
What's that making you think of, Dr. Moher? Are you?
Oh, I'm just like, it's a bit unusual, but I think that's probably not. I think I'm just kind of I was thinking like maybe if their section rate, like if their complication rate was different after their like if the doctors have been doing people more repeat sections than the ACs, but if there's no difference, then that's really good. I think to support the non-inferiority, all right. So.
Kriti, I had a couple of points to make. A great presentation, thanks very much.
Very good.
So I think regarding your questions, it's very difficult to say about a non-inferiority study in this setting, but we also have to accept that it's an LMIC setting, and a study like this is probably the best that you can do. First, they haven't done a power calculation. At least I haven't seen that in the paper. So it's difficult to say why they selected the number of patients in each group. And also we know that in the doctor group there were more patients compared to the non-doctor group. So I think in that sense, and they also talk about some of the weaknesses of the study, that it's not a randomized control trial. Ideally it would have been better if it's double-blinded. That's what they talk about in their paper. But you can't do any double blinding. So there are some weaknesses in the study, which is obvious. But I think it is fair to say that sort of the non-physician associates who have done the obstetric procedures are safe to do the procedures that they have done. But it's very difficult to generalize that can handle any emergencies, especially emergency C-sections that they're doing. So I think in that context, it's difficult to generalize. So for a selective procedures, I think it will suit as a non-inferior study. That's just my recommendation.
I mean, there has been systematic reviews collating all of the papers, looking at physician and non-physician kind of surgeons for cesarean sections, and they've consistently said that there hasn't been a significant difference. So looked at it in my paper, and also Amy Wilson did it several years back, and there hasn't been a difference. Occasionally there's been some differences in some of the outcomes. So for example, perinatal outcomes were a little bit worse with non-physicians when I did the analysis. And hysterectomy rates were slightly higher in physicians, but when Amy did it, again, there wasn't very much difference. So I think all of the papers that have been published on this topic kind of seem to say the same thing. And I think we probably just need to focus more on kind of keeping up their training as opposed to focusing on whether they're good enough.
I mean, from my experience, just being in an MIC setting, and I've visited Freetown, the doctors are getting will be very similar to what the ACs are getting, given the volume of work that they have to do, and there wouldn't be as much demarcation in terms of if there's a normal C-section that needs to be done, they'd give it to an AC the same way they'd give it to a doctor. And so I think so in terms of that, they'll be getting very similar experience. Trainees, and actually a lot of the time the trainees are the actual obstetric trainees or surgical trainees in whatever speciality, sometimes don't even get as much experience as the ACs because they'll be busy doing other jobs related to administrative roles of a doctor, as opposed to the ACs who'd be doing a job which would be just to operate or just to deal with patients. So actually, I think in this setting, I think it's safe to say that, the data does kind of support AC as a viable option for surgical management of patients, I think. So
yeah, agree. And when I was in Malawi, actually, the clinical officers were far more experienced than doctors, because the doctors that were on the show were interns, basically fresh out of medical school. And the senior interns were those who'd been there for 3 months,
Yeah.
as opposed to the clinical officers
Yeah.
who'd worked for
The
many,
clinical
many years.
officers are the backbone of experience.
So you've got to look at kind of not just what they are, but how many years they've done.
And sometimes it's not even just the years, because I've just come back from Ghana, and I was working with an orthopedic trainee. He's done 4 years of orthopedics, and he's come out to a district general to work with one of our teams, and the guy working the clinical officer in the district general has done more than the orthopedic trainee, in terms of operations, because in the district general he's just expected to get on with it, with the traumas, even with some of the elective stuff, because with what they have. So it's not just about the time taken, it is to some extent the experience that they're getting in that time that they're there, or that they're working.
May I ask the suggestion from this paper, and again, I apologise for not reading it, is in Sierra Leone that there is elective caesarean sections. That's not something I'm familiar with the sub-Saharan African countries I've been in. Is there elective caesarean? Everything I was is emergency.
In Malawi they have them. I don't know about Sierra Leone.
I don't know if they mentioned if they were elective. I think that in the paper.
It seemed to suggest the ACs did more elective and the doctors did more emergency. But
I don't think in the paper
it
said it was elective, was it? Chrissy?
Or was it day and night
So
was the difference?
Essentially, in the paper, it says that the Sierra Leonean government initiative to train ACs was more to manage the emergency workload. It doesn't actually give us any numbers about the elective workload there, but I would assume, considering the reason for their training in the first place, maybe that is not the right assumption, that they were mostly in places trying to deal with emergency surgical procedures, which perhaps reflects the distribution of where there are more ACs than doctors, and more doctors than ACs. So like you said, for the tertiary centre, there were way more doctors than ACs, whereas at one of the district hospitals, it was more ACs than doctors. So perhaps that reflects the caseload of emergency versus elective surgeries they're seeing, but that's just
The only other thing I would say is probably not really mentioned or picked up by this paper is with obstetrics, it's not about the cesarean, a large part of it is avoiding the cesarean section in the first place and knowing when it's actually indicated rather than whether you can do it or not. So, you're a better obstetrician if you can avoid the C-section than knowing how to do it. But yeah, that's just a side point.
Any other thoughts from the floor? Anything from our medical students? Sorry, I don't think they have access to microphones, so I'm vigilantly monitoring the chat. It must be quite intimidating when I say, can we hear from medical students, and they just all run away. Okay. All right. Thank you very much. Are there any final thoughts before I wrap up?
I think it was a very enjoyable journal club, Kriti. You've done a great job organising all this.
Thank you very much, everybody, for attending. It's greatly cheered me up at the end of not a very tearful day at work to see so many interested faces.
Yes, you've done it. It makes it more appealing to come back to the next journal club.
Yes, absolutely. Do turn up. I think it would be really great to have your input into what sort of articles we could discuss at our next journal club. So sorry to those who be caught by surprise with our second article today. So this new format was just trial to try and maximise discussion time, as opposed to just having a more of a didactic session. So if anyone has any suggestions for the papers that we could discuss at our next journal club, please do email us. Email the GASOC email, the events email, my email. I monitor all of them. Let us know. Let us know what you think. So thank you very much for coming. Have a good evening.
See you.
Thank you.
Thank you.
The broadcast of Facebook Live has stopped.
Copy the stream.
So that was via face.
So we've just managed to get it sorted on the Blue Jeans to have our Facebook live stream. We have been doing the YouTube streaming for most of our journal clubs through like a third party webcam, which you've been doing. But yeah, now Blue Jeans, we've got this app that syncs in with Blue Jeans, and we can live stream directly to Facebook Live. And the link is on our website. So if you go on our website.
So people just log into their Facebook account?
Yeah.
That's excellent.
Yeah, and if you go on our website, on the front page, you just click on the link and it should take you straight to the Facebook page on gasocuk.co.uk. So it is there. It's just trying to get the word out a bit more people watching.
Is there a tentative date for the next? Still.
It'll be in 2 months, so expect it in March sometime. Cool.
That's great.
Thank you very much for coming.
So many people got some nibbles.
I know. Yeah, we should have. Sorry, I thought we were.
How long has the journal club been happening here?
At the college, this is the third one. Third one
Okay.
at the college. Yeah.
Okay.
Before we were doing it at King's.
Yeah, that's, I work at King's and I would have been an attender pre having a baby and stuff, and I dropped off.
Yeah, and then but yeah, King's started to charge. Well, they wanted to charge us.
Oh.
So despite Andy Leather trying to help
It's
out.
going to charge you.
Yeah, they wouldn't let us use any of their rooms for free anymore. Because Andy was initially like booking them as the like MSc room, but
And then they do.
yeah, and then I don't know what happened, and then they wanted to charge us, and then the college was very nice and said, you can come and use our room for free. And they're really good, like they help set up everything, give us their webcam and all that.
Yeah, it does not look good for King's. Okay.
Yeah, but yeah, college are very accommodating, so can't complain.
Better than our college would be. Sure, our college would be charging.
So yeah, 2 months time, and yeah, check out our website. Hopefully, keep you updated. Sign up to the mailing list if you haven't already. We have. Okay.
Have you just had a new committee? Have you just had a new committee election?
So our committee periods or terms are 2 years. So we've had a couple of people who have had to step down. So we've just selected 2 new surgical and 2 new anaesthetic partners. We've had because we had a change in president.
No, I think you should update the website, so I'm trying
Yeah.
to find out who you all are.
Yeah, I'll put that up. We haven't even decided what we've just
Yeah,
finished.
we're still like.
Yeah,
still.
because people all dropped out, we've had to employ or nominate 2 extra people into the committee because our president stepped down, so we had to have a new president all of a sudden.
So who was the president?
So the president actually, we didn't say it, but Noel is our new president
Yeah, in Scotland, is it?
in Leeds. Where
The gentleman.
yeah,
the
he was,
magistrate.
so he's our new president now.
Yeah.
Because Sarah stepped down, and so that meant that he was our surgical rep. So that means we need a new surgical rep. So we just had to sort that out, and then we had to have an anaesthetic rep because someone's gone to where have they gone to? Where have they gone to? She's gone abroad. I can't remember where. Africa somewhere.
It's
And so she's gone for 6 months. And so she said that she wants to step down so that at least in that 6 months someone could cover her position.
And is Cat Ford still involved?
Cat Ford, no. No. But she's
Did they go to New Zealand or Australia? Her and Lily.
yeah, they went. I think
New
she was there last year. I don't know if she's back.
She should, yeah.
But she's not been in the committee for about almost a year.
Okay.
Almost
Because
a year.
the only face I'm recognising from like 3-4 years ago is I've forgotten his name, the lad in Scotland. Yeah.
Oh, sure. Safe journey home, guys.